Milind sir, is it visible? My screen?
Hello.
Sir. My screen is visible?
Yes, visible.
Okay.
Make it full screen.
Yes.
Okay. Good morning, all of you. My name is Milind Parai, Assistant Professor, Department of Electronics and Telecommunication Engineering, Sardar Patel Institute of Technology. We are starting with the session 2, and the speaker for this session is Dr. Lancelot Pinto. He is a consultant respirologist, PD Hinduja National Hospital and Medical Research Center, Mumbai. He is going to talk on technology in the medicine. So before going to start with the session of Dr. Pinto, I am going to give a brief introduction of Dr. Pinto. He is a gold medalist at the DNB examination in respiratory diseases in 2009. He trained at the McGill University, Montreal, Canada during 2010 to 2014, during which he completed a master's degree in epidemiology and clinical fellowship in the sleep medicine and COPD rehabilitation. He is active researcher and over 60 peer-reviewed publications and is a peer reviewer for a number of leading journals in the field. He also has collaboration with University of Cape Town, consulted for the World Health Organization and USAID with McGill University. His area of interest include management of severe COPD, drug resistance TB, smoking cessation therapy, and the management of sleep disorders. Okay, with this introduction, I welcome Dr. Pinto, and sir, please take charge and enlighten us with your knowledge.
Thank you, Dr. Milind. I'd like to thank you and Dr. Amol and his team for inviting me to this meeting today. Most of what I'm going to speak about will be my own personal experiences with technology and medicine and the principles that I have learned along the way. And I think this would give you kind of a perspective of what a physician would like technology to evolve in terms of things that how we can improve patient experiences, improve patient care with the use of technology. Is my screen visible?
Yes,
Yes,
sir.
sir.
All right. So let's begin with medicine and the opportunity that we have in India. So this is taken from the Mint. This was an article which was done a year back, which talks about health as traditionally always having been a low priority, unfortunately, in India. And when you compare it to the rest of the BRIC states, so if you look at even a country like Brazil, has 3.9% of its GDP, which is spent as public expenditure on healthcare in 2018. And if you see other countries, a country like the United States spends about 14.3% of its GDP. Germany spends 9.5. China spends 2.9. And if you talk about India, India spends about 1.28% of its GDP on healthcare, which is unfortunate, which is a very, very low amount, considering the fact that we are not considered a low income nation anymore. We are considered as part of the LMICs, which is kind of a middle income nation. Now, the good news is that the government of India plans to increase this public health spending to 2.5% of the GDP by the year 2025. So that's close to doubling of what the current spending has been. And if you look at the previous slide again, this spending has been low for the past decade. It's not budged much over the past decade. But the hope is that by 2025 we will actually double this spending. I think COVID has been an eye opener as well. I think everybody has realized that our healthcare systems are nowhere close to the level of, forget about the level of sophistication, even the level of ease, the level of contact that we need. We've seen none of that happen during COVID, and we've really struggled. And I think this has been an eye opener and will hopefully push this agenda of increasing spending in healthcare. There's also a strong thrust to increase investment in the public sector. So not only the private healthcare sector, which deals with cutting edge medicine very often, but there is a strong move to improve the reach of healthcare to the lowest strata of society. Now, what are the areas where we need to focus? So, as engineers, as people who will work with us in the future to develop tools to help patients, to help individuals, I think the move before COVID, of course, COVID has changed things, hopefully temporarily, hopefully in about 2 or 3 years from now, COVID will be a thing of the past and we will be back to focusing on the bigger, more chronic illnesses that our country faces. And the top non-communicable diseases in India are cardiovascular disease, diabetes, chronic obstructive pulmonary disease, cancers, mental health disorders, and injuries. So a lot of our focus in healthcare has focused on infectious diseases so far, diseases like malaria, diseases like dengue. Uh, a lot of our expenditure has gone into taking care of these infectious diseases. And now, as we get more prosperous, there is an understanding that lifestyle diseases, non-communicable diseases, are going to be the major thrust. I was part of this Niti Aayog commission, which seems to be very interested in investing in non-communicable diseases. And there are three top areas of interest where, of course, cardiovascular disease, diseases such as chronic obstructive pulmonary disease, which is an area of interest for me, and I will speak more about it during the course of this conversation, and cancers. I think these were the main three areas that the government would like to focus its interest on. This was data from 2019, which looked at 2018 to 2019, which looked at about 6.5 crore individuals who were screened at government clinics. It was found that about 6% were diagnosed with hypertension, 4.75% with diabetes, 0.3% with cardiovascular diseases, 0.1% with stroke, and 0.28 with common cancers. Again, suggesting that if you add all of these together, and this doesn't even talk about COPD, which is the third leading cause of death in our country right now, if you add all of these together, close to a fifth probably of all illnesses that present to government clinics would be non-communicable diseases. So I think this is the area that we need to focus on in terms of improvement, in terms of betterment of healthcare sector. If we look at the size of the healthcare market in India, and this is the projected size of the healthcare, this is in billion US dollars. It's about 280 billion US dollars today. But within 2 years, it is expected to touch $372 billion. And if you look at the trajectory, it's an exponential growth. If you look at from 2008 in this graph to 2022, there has been a consistent exponential growth in the healthcare sector and the healthcare market in India. So this is clearly one of the areas of interest for a lot of individuals. So what are the areas in which technology needs to innovate? So as a clinician, when I speak about technology in medicine, what are the things that I'm thinking of? So we think of diagnostics, and again, we've realized, for example, even with COVID-19, that greater the testing, greater the reach, more the individuals that you can reach out to, more quickly can you instill therapies and save lives. And I think diagnostics is becoming a focus all over the world in terms of changing healthcare. So this happened for tuberculosis. There was the Gene Expert, which was developed, which was a molecular diagnostic test, which was a game changer. And once it came on board, we realized we were screening a lot more individuals, we were testing, and we were turning around the testing time really rapidly, resulting in more individuals being put on therapy as soon as possible. So I think screening and testing is going to be a major thrust. Therapeutics, of course, is going to be a major thrust as well. So once you diagnose individuals, so far in the history of medicine, a lot of our medicine has been one size fits all. When we do randomized clinical trials, when we do studies, we've always looked at averages, we've looked at means, we've looked at what is a drug or what is a therapy that is likely to give most individuals the maximum amount of benefit. However, with computational energy becoming more and more accessible, becoming more and more inexpensive, I think we're realizing that this one size fits all is not going to work in the future. We are getting more and more into the realm of personalized medicine, in terms of precision medicine, in terms of phenotyping, as we call it, where individuals are phenotyped. So one disease is not just one disease. That same disease can behave differently based on the age of the individual, based on the sex of the individual, based on other parameters. And I think an area which again needs to be worked, which is probably the most underserved among these, and is probably as important as any other area, is behavioral interventions. So you've diagnosed somebody, you've started treatment, but how do you make them adhere to treatment? How do you remove the stigma from the disease? How do you make individuals change their healthcare behaviors to optimize their health? And I think technology has a huge role. Even simple things like wearables, for example. Wearables have changed the market in terms of individuals realizing how many steps they walk, individuals being sensitized to their unhealthy behaviors, and therefore hopefully we will cross that barrier from sensitization and understanding that these behaviors are not correct to actually changing such behaviors. And I think this is a strong area to focus on. As engineers, I think a lot of your attention possibly in the future should also be focused on changing behavior and modifying behaviors and influencing behaviors, because without this, the other two still remain incomplete. So what can technology add to medicine? So we always think of technology in terms of sophistication. We've always thought about cutting edge, making it more and more hi-fi. As individuals who look at technology from the outside, we are always influenced by science fiction. We are always influenced by things that seem almost extraterrestrial or seem almost out of space. And this is one aspect that technology can definitely add. So precision is definitely one aspect that technology can add, and personalization, individualized medicine. However, I think in a country like India, while precision is great, and precision hopefully will get more and more inexpensive as we go forth, I think reach is something that we need to focus on strongly as well. Reach to from tertiary care institute. So it's okay to say that, I will add technology to a tertiary care institute such that everything is cutting edge and we have the best that the US has to offer. But I think it's also important to improve reach. We should be able to serve somebody in a rural village in as well a capability as we can in terms of technology. And the things I think that are important for reach, when you're looking at technology from the concept of reaching the poorest man in this country, I think three things that we need to focus on, and I will be speaking about how we worked in some of these areas. You need devices, technology, whatever you're speaking about to be compact. It cannot be huge and bulky and have to be moved from one place to another, dependent on a lot of electricity, dependent on a lot of rechargeables, renewables. It's not going to work if that's the case. It needs to be compact. It needs to be cost effective. So cost is a strong driving factor in a country like India. So you cannot have something that's compact, but it's also very expensive and therefore cannot reach the grassroots. And the third thing is ease. So we have a huge manpower shortage. We are probably, again, unfortunately, we are a country in which the doctor to patient ratio is very low. We are a country in which technical expertise is not that great at the grassroots level. And therefore, whatever we design, whatever we think about in terms of technology has to be something that's easy. That should be, you should be able to train a grassroots healthcare worker to be use it to use it. And then you could think of it in terms of screening. So let's at least screen the ones who are most likely to die. Let's screen the ones who are most likely to have complications and move them to a tertiary care center. So screening would be an important thing, and this can be done by grassroots workers at the lowest levels in terms of the healthcare system. The third thing that technology can add to medicine is empowerment and patient centricity. So if we use technology to identify themes, to identify behaviors, people are using things like search engines to identify what individuals really want, what are individuals searching for, what are individuals desirous of when it comes to certain technology. That makes it patient centric. So a doctor may think that a particular device is great for diagnosis and a particular medicine is great for an individual, but at the end of the day, the individual may have his own needs, may have his own belief systems, may have his own structure in which he or she thinks. And I think technology needs to use the best capabilities available to identify this patient centricity. So let me give you a simple example. So we prescribe inhalers to everybody, and we as doctors are extremely confident that inhalers are the best possible things for diseases like asthma and COPD. But we also know that inhalers are hugely stigmatized in India. And this is a problem. So even though we have a really good drug, which is inexpensive, which is compact, which can be used by anybody, as long as we don't understand why these behaviors are so deeply entrenched and how we can change it, technology is not really going to add much to a field of making an inhaler more sophisticated, making it more stylish, making it more compact. So I think empowerment and patient centricity is something that needs to be added in terms of technology contributing to medicine as well. So let me now talk about some of the things that we have learned along the way, some of the diagnostics studies. So diagnostics is an area that's close to my heart. That's something that I feel very passionate about when it comes to my own research. And I'm going to share with you certain experiences that I had. So again, I think it's important. I think for us, our focus has always been improving reach, also because we may not have the necessary wherewithal and technology to work on it, which is where collaborations are extremely important with technology. But for us, a lot of our research very often focuses around cost, portability, and ease. So something that's low cost, something that's portable, and something that can be done by anyone. So let's begin with one of the areas that I work on. So COPD. So COPD is a disease which generally happens to individuals who've smoked at some point of time during their lifetimes. And as a result of this smoking, when they tend to grow older, they tend to get breathless, they tend to have cough. It's a huge burden on the healthcare. It's the third leading cause of death in India. Unfortunately, in India, it's not only the smoking that leads to COPD, but it's also the biomass fuel exposure. So a lot of individuals in India cook food on chulas or on shigaris, which essentially involves the burning of biomass. So they burn crops, they burn coal, they burn biomass fuels, and the fumes that come from the biomass fuel also contribute to COPD in India, leading to a huge disease burden. So the question that was asked in the study was, if as a doctor I'm sitting, or I'm sitting in a peripheral healthcare center and I have individuals coming to me, if I have 100 patients who visit me with COPD, just based on my examination without any tests involved, what is the percentage of individuals that I would miss? And this was a study done in South Africa. It was called the Didasco study. It was done in primary healthcare. And what they found was that 1 in 2 individuals would be missed by a general practitioner if you rely only on your clinical skills to diagnose COPD. So for every patient diagnosed with asthma or COPD, there is one that remains undetected. This is how COPD is diagnosed presently. This is what we call a body plethysmograph with the spirometry. This is what we do at Hinduja, for example, at a tertiary care institute in a metro city. This is how we would diagnose it. So if you see the equipment, it's bulky, it occupies space. It's very heavily dependent on the technician. You need to have really good technicians. If any one of you have had a PFT, you will know you have to blow really hard. You have to follow certain maneuvers. You have to have a technician who invests that kind of time and energy in you. The equipment costs somewhere close to 1 crore. If you look at the body pleth, it's about 50 lakhs. If you look at the spirometry equipment, it can be about 50 lakhs. So it's expensive. It's very dependent, technician dependent. It takes up space. It needs electricity. So a lot of things that are difficult to replicate at a primary healthcare center. So we looked at something called a COPD-6 microspirometer. This is a handheld device. If you see the photograph of the lady, she's one of our PFT technicians holding it for demonstration. That's how small it looks. It's small and compact. It basically runs on batteries. It's a screening tool for COPD. It's used for case identification. Displays something called the FEV1 by FEV6, which is one of the things that can be used for screening. And we did a study. So this was presented at the European Respiratory Society Congress a couple of years back. We basically enrolled 1,332 subjects who were having a spirometry. The gold standard was spirometry, which they had come as part of health checkup, as part of other reasons. They had come to have a spirometry. We also subjected them to microspirometry or a handheld spirometry. Now, 9.2% of these individuals, when tested with the gold standard, which is the big spirometer, which is the expensive spirometer, so about 9.2% of individuals had COPD by definition. When we use the Vitalograph, which is the handheld spirometer on all these individuals, the negative predictive value of the Vitalograph was 99% when we did the study, which means that if the Vitalograph said that you didn't have COPD, in 100 individuals, 99 of them would actually not have COPD. So a very good negative predictive value. The sensitivity was 91.9%, which is not bad at all, with the specificity, which is slightly lower. So you wouldn't want to diagnose the disease with this device, but it's a very good device for screening. So if you want to use it at a primary healthcare center, screen individuals. If the individuals turn out normal, the probability that they have COPD is negligible. If they turn out to be abnormal, that's when you could refer them for confirmation. So of the 10 patients with COPD which were missed out by the handheld device, 2 were in gold stage 1, 8 were in gold stage 2. So they were in early stages of the disease. So even the ones which were missed out were mild COPD, did not tend to have severe COPD. So you almost won't miss out anybody with severe disease. This is what the graph looks like. It's a little confusing. Let's see if my cursor works. So this is the current threshold that we use for COPD. This horizontal line So when we use a spirometry, anybody below this line actually has COPD. This vertical line is what we found with the microspirometry. And if you see, we caught almost everybody below the horizontal line was caught by a microspirometer. These were the 8 patients who were missed by the microspirometer, but like we discussed, most of them had milder forms of the disease. So when you talk about the 3 criteria, so the cost of a handheld spirometer in this study was about, somewhere between 4.5 to 6,000 rupees, as opposed to the 1 crore that we spoke of. The portability, it's a handheld device, runs on batteries. The ease of use, you do not need a technician. There is a beep that happens when a person blows. When the beep happens, the person stops blowing. Very easy to train somebody at the grassroots level to use it. So I think this satisfies all the criteria that we were speaking about in terms of trying to make a device more reachable to people at the grassroots, to people at the primary healthcare level. The other thing that we need to leverage now, thanks to COVID, almost every household seems to have a pulse oximeter. A pulse oximeter is inexpensive. It can cost as low as 1 to 1,500 rupees. It gives you the oxygen levels. Now, the oxygen levels are a crude measure of severity. So again, a wonderful test to be used to know who is bad enough that they need to be immediately shifted to a hospital. So if it's normal, it may not say much. You could still have a lot of respiratory diseases in the mildest form in which your oxygen levels still remain normal. But if it's abnormal, you will be picking up a cohort of individuals who have severe disease, therefore more likely to die, therefore more likely to have complications. And these individuals could then be referred to a tertiary care center. So pulse oximeter is again an example of a device which is small, compatible, compact, not very expensive, doesn't need any training whatsoever to use. And this is again where technology has played a big role in medicine. The next thing that I will speak about is what we call a digital stethoscope. This is something that I've had the pride of working with IIT Bombay. This is something that we developed with BETIC. BETIC is a cell at IIT Bombay which works in close collaboration with doctors to try and develop devices. This is what the device looks like. It's a small, compact device which basically can be attached to any stethoscope. So if you see my stethoscope here that I'm wearing, it's attached to it. So this is this. I just had to detach this part, attach this, and reattach my diaphragm. What it does is it basically amplifies sounds. Number one, so sounds are louder than what they are if you heard with the naked ears. The second thing that it can do is it can record sounds. The third thing in its latest iteration, it can do is it has Bluetooth capability. Thanks to the Bluetooth capability, you can just wear a pair of Bluetooth headphones and have the chest piece at a distance. So this is a wonderful device even for a disease like COVID, for example, where you don't necessarily want to be in close contact with the patient. If the patient himself can put the chest piece on the chest and you listen to it with a Bluetooth device, you could hear sounds transmitted to you without actual physical contact. Now, this is again a great device in terms of telehealth. So basically, the idea eventually is to help this percolate down to the grassroots. If it does percolate to the grassroots, people who are confused, say, supposing you have a primary healthcare doctor who's treating somebody, he or she is listening to some sounds in the chest, which do sound abnormal, but they don't really know what it means. They could record those sounds and transmit it to somebody at a higher level, at a tertiary care center, who could then advise them as to what the next step should be, what the next test should be. So think about this in combination. You have something like this, you have an oximeter side by side. You will identify patients with a severe disease. You will be able to get a sophisticated analysis. We are moving forward with this project to try and analyze breath sounds. So that's the next step, where we will be trying to look at the analysis of sounds in itself, collect a huge amount of data. The IIT team has resources to artificial intelligence, and they will try to analyze these sounds such that even a person eventually at a primary healthcare center will put the stethoscope to the chest of an individual. The sounds will be analyzed. There will be some sort of output that would be given, and this can then be transmitted. Decisions can be made based on this. So again, if you look at the components, this is probably something that engineers here would be very interested in. I don't understand everything that this means. High fidelity amplification, uh, sound recording through the computer, visualizations, and then transmission. This is now going to be trialed. We are actually going to trial it in a real clinical trial to see if it actually changes patient healthcare and can improve patient behavior, improve treatment of patients. So this is something that we're very excited about, the digital stethoscope. And let's look at uh, so if you look at the features, and this has actually made it to industry, right? So this was developed as an academic exercise, and it's now actually being sold on the market through a company called IU Devices. So it has high fidelity amplification, ambient noise reduction, it's easy to attach, stores data, and preserves the look of the stethoscope. So if individuals want to hold on to the classical look of the stethoscope, you're just attaching it to any stethoscope. So there are companies that manufacture digital stethoscopes, but the cost ranges anywhere between 30, 40, 50,000 rupees. This is an attachment that can be attached to any existing stethoscope. So if you look at the cost, I think it's being sold under 10,000 rupees. So it's not too expensive. It's very portable. And again, the ease is basically in the ability to easily record these sounds, easily transmit these sounds, such that a person who may not necessarily have the expertise to analyze these sounds can then transmit it to somebody else. Let's move on to another disease that I am very strongly interested in. It's a disease called sleep apnea. So sleep apnea happens to individuals who snore loudly, and as a result of the snoring, they very often choke at night, their breathing stops, their oxygen levels dip, and this is strongly associated with various cardiovascular and metabolic abnormalities. So it's very strongly associated with high blood pressure. So if you know individuals who snore and have high blood pressure, they must be assessed for sleep apnea. And it affects close to 5 to 10% of adults in India. So that's not a small number by any yardstick. Now, currently, if you want to diagnose sleep apnea, you need to diagnose it with a sleep study. And this is what an individual having a sleep study looks like. So there are bands on the chest, there's a band on the abdomen, there are electrodes on the head for the EEG, there are chin electrodes, there are nasal sensors to detect flow, there is a leg electrode to detect movements. So it's a little cumbersome. Individuals who have sleep apnea tend to be very sleepy, as a result of which most individuals, despite being set up like the way it looks in this photograph, do end up sleeping and give us valuable information. But clearly, this is not desirable. This is also an expensive setup, so to take it to a village is not going to be easy. The analysis of this takes expertise as well. Look at what it may come down to. So this is using a technology called peripheral arterial tonometry. So basically, the concept is that there are certain bodily changes that occur when you have sleep apnea. When your oxygen levels dip, your heart rate goes up a little bit. Your the tone or the level to which your blood vessels are constricted change a little bit during those events. And based on that, these guys have developed an algorithm. The algorithm predicts the sleep apnea based on these surrogate changes in arterial tone. And this is all that it is. You just put in a small little sensor. There, the sensor sticks to your finger. You use it every night. You use it for 6 consecutive nights. They've figured out a way in which the data is directly transmitted to a central hub. The central hub analyzes it and gives out a report in terms of the severity of sleep apnea. And studies have shown a reasonably high degree of sensitivity and specificity with devices like this. So this is FDA approved. And I think, if you look at the previous photograph again, we've moved a huge amount from something that's as cumbersome as this to something that's as simple as this. Again, I'm not suggesting that this would completely replace sleep studies, because the level of sophistication that you get in sleep studies is higher, the level 1 sleep studies that we speak about. But this would be an excellent screening device to initially screen individuals who might have a high probability of sleep apnea. So again, if you look at peripheral arterial tonometry, low cost, I think it's about 5,000 rupees is what they're selling it at. Very portable, very easy to use by anybody. And it has one additional benefit, which is now becoming an important focus area. And again, as technology developers, this might be a focus area that you also think about when you're thinking about future projects, that this is one-time use. So this device is sent to an individual. The individual uses it for 6 consecutive nights and just disposes it after that. The idea being, in times of COVID, people don't want to undergo things, don't want to be strapped up to things that are being used by other individuals. They want everything to be as disposable as possible to reduce the risk of contamination. And I think this might become an area of future research as well, to make things as disposable as possible, with, of course, the caveat that you would want to leave a low carbon footprint, etc. as well. So what about sophistication and precision? So this was when we spoke, so these examples were when we spoke about diagnostics having a greater reach, reaching out to the periphery. Let's look at, so this was a study that we did. So again, COPD is the third leading cause of death in India. It's currently diagnosed with spirometry, the blowing test that we just described. Most individuals, unfortunately, when they are diagnosed in stages 2 to 3. So stage 3 is reasonably advanced when you've lost more than 50% of your lung function. Stage 2 is when you're somewhere between 50 to 80% of your lung function. So unfortunately, the human body is designed such that you can lose close to half of your lung function and yet not perceive that breathlessness if you live a sedentary life. If you're a marathon runner, it's a different story. But if you live a sedentary life, you could actually lose close to half of your lung function and not realize it unless you have something like a spirometry. So we realized that all over the world, there is a realization that we are diagnosing people at a relatively advanced stage of the disease. And the question is, can we diagnose these individuals earlier? This was a study that was presented this year at the ERS Congress. This is a student of mine. What we did was we took individuals who had smoked in their lifetime. So they had smoked more than 10 years in their lifetime at some point of time in their lives, but they had a normal spirometry. So the spirometry wasn't bad enough yet. They obviously didn't have symptoms. They were having spirometries as part of routine healthcare or routine health checkups. And we said, let's look at whether we can figure out whether these guys already have smoking associated lung damage even before the spirometry has picked up anything. So let's try and get a little more sensitive than spirometry to see if we can pick up something. And what we did was we subjected all these individuals to a chest CT or a CT scan of the lungs. This was done with a low dose protocol because we are cognizant of the fact that you're exposing people to radiation. So we used a low dose protocol for CT scanning. And what we found was very surprising that close to 50% of all individuals had signs of early COPD on their CT scans despite having a normal spirometry. And these changes, if you look at this table, even in the age group of 30 to 40, 3 out of 11 individuals had signs of COPD already. So they were smoking in their 30s, they've not touched 40 yet. And yet there are signs which are seen on the lung at a very early stage. And this goes on throughout. So once you touch 60, 5 out of 6 individuals have these changes. And therefore, a CT scan might be something that could be used to pick up the disease at an earlier stage. This helps from multiple reasons. If you pick it up at an earlier stage and the individual is still smoking, you can really set off a red flag saying, listen, you already have problems associated with smoking. You definitely need to stop smoking to prevent further lung damage. You can follow these individuals more closely and make sure that they do not present to you at a stage where irreversible damage has been done. You can start them on treatment early. So this is using sophistication. So we're talking about CT scans, we're talking about expensive tests. This, as of today, is not something that you might be able to scale up and reach to the lowest segments of society. But this is another use of technology in medicine, which serves improving sophistication, improving earlier diagnosis, earlier treatment. Again, I've had the fortune of working at the Indian Institute of Science right now. This is an ongoing study with the Indian Institute of Science where we're looking at breath sounds. So every individual who gets diagnosed with COVID, who's in our hospital right now, for example, is given a simple, so there's a website you log into, you give in your details, you cough and you breathe. There are certain maneuvers to leave certain sounds, and these sounds are recorded. They will be analyzed using artificial intelligence to see if there is some sort of a signature. So can we pick up individuals, who may, from the comforts of their house, using a cell phone, go onto a website, cough out, and based on the sounds, would we be able to tell them that, listen, you may have a high chance of having COVID, so please go immediately and get yourself swabbed? Or can we tell them that, oh, listen, you may have a low chance, wait a day or two, maybe, look at it as an ongoing, evolving thing. So this is again in its early stages. Again, I don't understand all of this because it involves artificial intelligence techniques. But basically what we are doing from our end is the individual just needs to have a phone. I think there's a crowdsourced data set as well. So you can do it from their website. You can leave your breath sounds for normal individuals with COVID. We're looking at different severities. So they wanted a subset in the hospital as well, which is where we contribute, but they have a huge amount of patients from the community as well who will be providing information, and these will be analyzed. So this is again sophistication. You need a smartphone. You need to be able to record these sounds. You need to develop these algorithms that will analyze. Of course, this might be cutting edge in terms of the technology, But if we surmount this technology, this might be accessible to individuals across the country, given the fact that cell phone penetration seems to be very wide. We did similar things for tuberculosis. So this is my work with the University of Cape Town, where we tried to develop a radiographic scoring system for chest X-rays to predict tuberculosis. And this was crude. This was based on what individuals scored. They looked at X-rays on X-rays on a computer screen. There were certain guidelines which were given how to score them, and based on those scores, we tried to develop a scoring system which would predict TB. Unfortunately, as most scoring systems as of now for TB using radiology, the sensitivity tends to be very high, the specificity tends to be very low, especially when you're doing it in countries which have a high burden of TB. So lots of individuals have scars on the X-ray. So these individuals end up being screened. So they're positive screens, so sensitivity very high, but a lot of them do not actually have TB. So the specificity ends up being low. But this now we know is being taken forward. So this was a crude version of it. We know that artificial intelligence is being used to look at different areas of chest radiographs, to have computer algorithms analyze chest radiographs to try and figure out the probability of tuberculosis. And I think this is another example where cutting edge technology can improve sophistication. We did something similar for TB. So this was my study at McGill, where we looked at basically, till now we've assumed that everyone with COPD has the same disease. Whether you're young, whether you're old, you're male, you're female, we have a generalized constant prescription for everybody. But we are now realizing, and this is through something called cluster analysis, which involves something called principal component analysis, again, a lot of which is in the biostatistics, analytics domain, where we've realized that individuals can have different phenotypes. So we realized based on our study of the literature that there is a certain subset of women with COPD, for example, who in their 40s develop very severe disease at a very young age. And we have no idea why these individuals behave in this way, but this is a clearly defined phenotype across studies in different parts of the world. And therefore, we need to identify these phenotypes. The eventual goal, of course, is that with this kind of sophistication, with the use of artificial intelligence again, you would be able to predict who these individuals are, and you would be able to alter the course of the disease based on these predictions. So this is again precision medicine. This is the future in terms of analytics, where the one size fits all is not going to work, and technology has a huge role to play in this field. So not much of my research has been in the domain of therapeutics. So I'm just going to give you one simple example that we did here at Hinduja. So this was so basically drug-resistant TB is rampant in Mumbai. So around a quarter of all individuals in Mumbai who have TB have drug-resistant TB. Now, the way it works is that the day you get diagnosed with drug-resistant TB, eventually what determines your prescription is something called a drug susceptibility test. So the germs are put in the laboratory to grow. When they grow, they usually take anywhere between 3 to 6 weeks to grow. Once they grow, there are tests which are done on those germs, which give us a prescription, which gives us a report telling us which drugs will work, which drugs will not work for this kind of tuberculosis. Now, unfortunately, I have to start treating the patient today. The culture can take 6 weeks. The D.S.T takes 2 more weeks after that. So it might be a good 8 weeks from today when I will actually know which drugs work, which drugs do not work for this particular patient. Therefore, we try to analyze all we have a huge repository of cultures that come from across the city at our laboratory. What we did was we analyzed all the cultures that were available, looked at all the susceptibility patterns, and tried to formulate a best available prescription. So this is kind of an example where we used a derivation cohort where we took 6 months of data, we looked at all the cultures, we developed a rule saying that these are the 5 drugs you should give everybody in Mumbai who come on day 1 to you for treatment. We then used a hypothetical, the next 6 months data, we used that prescription on patients. This is a hypothetical modeling exercise where we say, had we used this prescription which we derived on the next 6 months of patients, would we be accurate in what percentage of patients? And we found a very high degree of accuracy. So if you notice this, the validation cohort looks almost identical to the derivation cohort, suggesting that for some reason there is a certain consistency in the pattern of cultures that we see at Hinduja or at our hospital. And these individuals would be best served by tailoring the prescription, not based on national guidelines, but based on our own guidelines, which we develop based on the cultures that we see. Again, this is a very crude, this is something that we did, so there's no great sophistication in terms of technology here. But I'm sure you see potential in this. I'm sure you see potential in identifying which part of the city, for example, certain individuals come from. Maybe there are different clusters. Maybe there are different predictors of what your eventual drug susceptibility could be. And I think this is a strong area of interest for those who want to apply technology to therapeutics. Behavior, again, I can't say this enough, but all of us as scientists always think about everything in terms of hard numbers, in terms of objective numbers, in terms of hard outcomes, and things like behavior often get neglected. And I think this is something that we need to work very hard on, to try and understand why patients do what they do, or why patients want what they want, or what exactly do patients with a disease need the most. So prioritize working in technology, using technology, prioritize the areas of research based on what your end user wants. So your patient is your end user. So do not go to doctors and just listen to doctors. Do not listen from what you hear the buzz around the world. You need to know what your patients want the most. And I think that's an area of interest in terms of technology. So for example, let's look at tobacco. So if you look at the bottom line, 42% of men in India and 14% of women in India, and 28% of all adults currently use tobacco in India. That's a whopping number. So close to, somewhere close to half of all adult Indian males use tobacco in some form. And if you look at the numbers, it's about 266 billion. So this is a huge number. So I run a tobacco cessation clinic at my hospital. And we wanted to know, we had reasonably high success rates, and we use scientific principles which are based on science all over the world. We use pharmacotherapy as is recommended. But at the end of the day, we wanted to know what really helped. So both in individuals who ended up quitting smoking, and what really worked for individuals who didn't. And this was our abstract, which we presented at the national conference a couple of years back, where we looked at facilitators and barriers for adherence to smoking cessation therapy. And this was qualitative research. Again, this I had a student from the behavioral sciences interning with me. She went ahead and documented these interviews that she had with patients. This was a cloud that was created from all the themes that were obtained. There's software that can be used for doing this. And based on this, we came to certain conclusions. We learned a lot, which we kind of implemented in the future of the tobacco cessation clinic. And I think these are areas that need to be worked on as well. Listening to patients, using technology to kind of try and figure out things. And this is already being used online, right? So we are currently looking at tobacco cessation again based on online data from Google. So I'm working with a group which is trying to look at ways in which, if a person searches online for tobacco cessation or smoking cessation therapy, they can be directed in some way to a website which will then put them in touch with an expert who will help them quit. So using search engines, using what is the need of patients to direct them in the right direction is where technology can play a big role. This is knowledge translation again. So most individuals don't realize this, but when you try to give up smoking, when you try to give up tobacco, of 100 people who try to give up tobacco, at the end of 1 month, 97 are back to consuming it. So it's a 3% success rate. Now, with pharmacotherapy, this success rate can improve tremendously. This is something that we published in Addiction, which is one of the top ranked journals for the field of addiction. And we tried to create something which was easy for a physician to put up on his wall. So this is a dartboard which we created, and the size of the center black circle in this dartboard corresponds to 3% of the page. So that's the probability that you will quit smoking off your own if you threw a dart at this and you were blindfolded, and just by random probability the dart landed somewhere on the paper. The probability that you would quit smoking on your own corresponds to that inner black circle. This probability improves to the outer green circle if you do it with help, with pharmacotherapy, etc. And then it moves to the size close to 98% of the size of the page if you make multiple attempts with assistance. And this is an attempt at knowledge translation, again using technology that people don't understand terminologies like 3% very well. But if you translate it into something that's more relatable, individuals understand things better. And this is another area in which technology can help, translating knowledge to help people understand things better. So I'm going to summarize with saying that we need to focus. So as investigators, if you do plan to work in the at the interface of technology and medicine, I think it's important to focus on diseases that have a need. And I think one of the major areas of focus should be non-communicable diseases from a long-term point of view. Right now, it might seem that COVID is the only thing that anybody's interested in. But from a long-term perspective, I think non-communicable diseases are going to be the biggest drivers of disease in India. You need to collaborate with experts and end users. It's very important to involve end users. A lot of ideas which seem very attractive to doctors and very attractive to people in technology have not been attractive to the end user at all. And I think it's important to engage patients at every step along the way. I think patients need to have a voice in determining what ways they would like technology to help them. So do involve end users along the way. When it comes to diagnostics, these are the three different ways in which you can approach things. You can improve reach, which I think is a great target for a country like India. So think of cost, think of portability, think of ease. You can also look at precision, phenotyping, individualized medicine, which is also extremely important. And as we know with technology, what starts off as being something very cutting edge, expensive, with time will get more and more inexpensive. So there's no reason not to work at the cutting edge as well. So sophistication with cutting edge technology also has a very important role, because you start off with sophistication, which serves maybe a small proportion of individuals, but with time, you innovate further to try and make it low cost. I think when it comes to treatment, artificial intelligence tools are going to play a very important role in phenotyping, in prognosticating, and in treating. So not all diseases are the same, not all individuals are the same. You need to tailor everything to the individual, and this is where precision medicine comes into place. We need to work towards adherence and behavior as well. Use technology to understand and improve behaviors of individuals. And like I said, I think it's most important to serve the end user. Let me give you an example for the use of CTs in COVID. Most of the science shows that the use of a CT is probably not needed at all in COVID. It does not determine whether you have a good course or a bad course. It does not determine whether anything needs to be changed when it comes to medicine. And yet, individuals have been CT scans have been used left, right, and center in COVID. Now we can pat ourselves on the back saying that we are a country which does CT scans at the blink of an eye. But is that really what the end user needs or wants? So I think we need to be responsible in the use of technology in medicine, combine what is the evidence base for a particular technology with what really influences disease, influences outcomes, and be as responsible as we can when we develop technology in medicine. Thank you.
Thank you, sir. There
Thank you,
are
sir.
few. Yes.
No, sir.
Should I take up questions?
Sure.
Yes.
Yeah. Uh, so there are few questions. Professor Ambawadi is asking, dear doctor, are the air purifiers available in the market, effective at home or workplaces? Is it needed to buy?
So again, this is an area where we need long-term research. It's difficult to know. So we know that air purifiers definitely reduce particulate matter. We know that the PM 2.5 comes down significantly with the use of an air purifier. There's a lot of research. I spoke at this work conclave last year where we spoke about how productivity, forget about hard outcomes, we think about things like disease, but even soft outcomes like productivity and air purity levels have been strongly linked. So there's a group in Harvard which has worked on this extensively, which shows that improvement in air quality can improve worker productivity. So I do think there is a role of air purifiers. Now, whether it influences disease in the long run or something is where we need research. Whether an individual who uses an air purifier all his or her life is less likely to develop complications later in life. I think that's an interesting topic of research. But in terms of day-to-day quality of life, I do think air purifiers make a difference. Now, whether the current air purifiers are adequate or not, I mean, I believe that at least the sophisticated air purifiers that you see do give you a PM 2.5 display, and I think a lot of our energies have been focused on reducing that to agreeable levels. And I don't. I mean, I think it's fair. I think there's no reason not to use an air purifier. The analogy that is often made is that of water. We've accepted water purifiers across the country as part of life. Maybe it's high time that we start doing the same with air purifier, given the fact that there doesn't seem to be much in terms of investment to actually bring the air quality down to healthier levels.
Yes, sir. There is one more question. There are some papers related to COPD detection using electrical impedance tomography. The device using EIT are also portable and non-invasive. Do you know availability of any commercial devices using EIT in India?
So not to the best of my knowledge. One of the things that we use is oscillometry for COPD detection now. So oscillometry is a little more sophisticated because it doesn't involve the individual doing the forceful breath maneuver. You can breathe normally like you normally would, and you can pick up disease. So that's been a big step forward. And oscillometers, I think we're going to see a lot more of oscillometry. I'm not too aware of electrical impedance tomography being used widely or being validated yet, but it's something that might be interesting, of course.
Okay, sir. Uh, I can take up some questions from audience. Means we have
Sure.
some of them from pharmacy. Maybe one or two more quick questions.
Sir, I have posted in the question answer.
Question
Mhm.
answer. I think it is. It seems incomplete. Just a minute. Let me check. Okay. What is the perspective of doctors about non-invasive blood sugar measurement? Can you elaborate what doctors are expecting in this field?
No, so again, I mean, it's not my particular area of interest, but if you could non-invasively measure blood sugar, I think that would be extremely useful to doctors in terms of you can give action plans to patients. It's very empowering to patients. So self-monitoring of blood glucose, I think there's a lot of literature that suggests that SMBG has actually changed patient outcomes. It lowers the HbA1c in the long run. It improves microvascular complications in the long run. So if you could do this non-invasively, I think this is a great area to work on because it's patient centric and it's likely to change outcomes in patients.
Okay, thank you, sir. Thank you for answering the question.
You're welcome.
Uh, Over to you, Milind sir.
Thank you, sir.
You're welcome. It was a
Amongst
pleasure.
understanding. Okay. Uh, Consider this a virtual memento as a token of gratitude from Sardar Patel Institute of Technology and from this Atal FDP team.
Thank you so much. Thank you very much.
Thank you, sir. Okay, we start with the next part of this session two. We have with us Dr. Santoshi Nagaonkar. He is a consultant urologist, PD Hinduja National Hospital and Research Center, Mumbai. He's going to talk on robotics in surgery. Before starting with the talk by Dr. Nagaonkar, I just brief you about him. So, Dr. Nagaonkar is MBBS, MS, and fellow at Royal Australian College of Surgeon, also a fellow at European Board of Urology, DNB of Urology and General Surgery. He also worked with Reliance Foundation Hospital and MRC Mumbai during 2014 to 2016. He also worked with the Newcastle Private Hospital, NSW Australia, during 2005 to 2014. He also holds some teaching position at under New England NSW, Royal Australian College of Surgeon, Australia, Flinders University, University of NSW. Dr. Nagaonkar also done some advanced training in a robotic oncology training Peter MacCallum Cancer Center, Melbourne. Also some advanced robotic training at University of Southern California. Sir has presented several national and several national event and conferences. Also published some papers. He also holds several awards in his name. I'm very happy to announce that the Week magazine, November 2020, covers the story of Dr. Nagaonkar. Amal sir, can you please? Yes, so you can see here the
Yes.
Week magazine covers the story of Dr. Nagaonkar. So thank you very much, Dr. Nagaonkar sir, to be here, and please enlighten with your knowledge to the participants.
Uh, I would request Nagaonkar sir to just brief all of us about this particular Da Vinci, and because it seems interesting. I'm opening this article.
Sure. Am
Yeah.
I audible,
Yes, sir.
Amol?
Yes.
Yes, sir.
Okay.
Yes, sir. So this is
And
the magazine front cover, and I would just quickly go through the pages, and then Santoshi sir, you can brief us about this.
sure. So thank you, Amol and Milind, and I really thank Sardar Patel Institute of Technology for inviting me. This is first of its kind. Actually, I'm doing it for information technology or technological institute. Any talk which I'm doing. So this article which came up last month as the main page article was about a patient who got operated by this robotic technology and how it changed his life. So he was diagnosed with just to give you a brief about it, he was diagnosed with a prostate cancer, and he was actually in a state of shock because he's been a marathon runner for the last 35 years. He's been running full marathon, and he's got a daily schedule of running. So being so healthy and health conscious, despite all these factors, he landed up with a prostate cancer which had to be operated. And how he recovered. So how the technology helped him in recovering uh, relatively quicker than the other technological or other surgical procedures or other uh, types of treatment modalities. So this article just covered about his entire journey about going through this diagnosis of prostate cancer and how it was picked up, how he got treated, and how we eventually conquered the cancer. So it's a nice read if you have access. It's available online, and it's a nice journey and story about this patient particularly. So
Yes, sir.
I'm going to basically give an overview about the robotics in surgery. Um, are my slides visible to everyone, Amol? Because this is first time I'm using Google Meet. So
No, no, sir. The presentation is not visible, sir.
okay.
You can start
So
presenting now.
yeah, I'm just clicking on to present now, and then
Present
it
now, and the
says
entire screen.
entire screen.
Uh,
Now it is visible.
yes, sir.
It's visible.
Yes.
Yes, sir.
So is the slideshow visible or even the presenter's view visible? So that
It is
should I
still in PPT,
present?
not in full screen mode.
Wait, right. Okay.
Now it is
Now
visible.
it's good, please.
Okay. So once again, thank you very much, Sardar Patel Institute of Technology. I'm trying to keep this kind of a talk as interesting as possible, showing a few videos and some pictures, because this may be a field which will be totally new to most of the technological people, though you are the guys who have devised this technology with the
Uh,
help of
Sir,
physicians
is
and
there
surgeons.
any brightness issue? I mean, I'm seeing it little darker. Is it the same for all? Melin sir, can you acknowledge? Or
It's
Ambode sir?
okay, sir.
Okay, no?
It's okay, sir.
Okay.
Okay,
I
okay.
got it on
Please
the
go ahead,
full.
sir.
Yeah, I got it on the full
Okay, okay.
brightness.
Please go ahead. Sorry to interrupt.
So basically, as this statement clearly says, it's not about adding technology because just because we can. It's about using the technology to create better clinical and economic options for hospitals, surgeons, and most importantly, patients. And that's why this technological advancement they take place in medical field. If you look at this slide, this is uh, a depiction of how the surgery used to take place a few hundred years ago. There was no introduction of anesthesia to the patient. The patient is being laying on the bed. Three assistants are holding the patient's leg, and the surgeon is trying to remove a urinary stone from the patient's urethra. So it was like a barbaric era. You can imagine how we have really evolved. Now, even if we are sitting in a dentist chair, we get anesthetized. So we are so much so careful about patient's pain factor and other factors. But we have evolved a lot. Now, what is a surgery? Surgery is a branch where we manipulate tissues in the body in order to diagnose, in order to treat or prognosticate a certain disease or the ailment. And the branch of surgery has also evolved. So in this picture, you can see the bottom of the arrow, you can see the freehand surgery, which is still the mainstay of our surgical field. We are still operating with our hands. We are still cutting open these patients and we are removing different ailments or different diseases. We are trying to cure them. But in the last 50 years, things have started to change. And the cosmesis, the pain, how the surgery could be made more uh, effective by keeping the incision of on the body in a least way has definitely evolved. So then we started with the minimal invasive surgery, where the laparoscopic surgery was invented, where the a keyhole incision is made on the body, on patient's body, and you insert long instruments and a camera inside, and you do the desired job. So suppose you have to remove a gallbladder or appendix, you just make a tiny hole instead of making a big cut over the body, and do the same job. You remove that gallbladder or the appendix and sew up the tiny hole. That's it. So that was the minimal invasive surgery. But again, it had its own limitations. Then we moved on to the robotic assisted surgery, which is the current uh, technological advancement. Of course, it was uh, started way back in 2001, and there has been a lot of advancement in that technology as well. And what we are looking at now, what we are facing, what challenges we are facing, or what we are getting into is surgery with full automation, and which is not far from happening. And there is a huge scope in this field, which all the technological people, those who are interested in robotics, should exploit for. So normally it takes about 20 years. That is called as the uh, uh, the, the technological advancement. So any technology, when it gets introduced, it takes about 20 years to prove its ability that it is a good technology. And this robot, which is right in front of your eyes now, has taken 20 years to be called as a safe mechanism to operate on a patient. Any patient who walks into the theater or gets inside the theater and sees this equipment, and he's been told that, okay, this is your surgeon, anybody is going to get really scared. But do we really have to get scared about this? No, because it's still a master and slave technology. Now, if you look at this picture, this is an original drawing which was made by Da Vinci, Leonardo da Vinci. This was uh, several hundred years ago, and this is still preserved in the museums. This was the first ever design made by anyone of a prospective robot. And based on this, later on, there have been a lot of research which went into engineering department, and they came out with the robotic arms, which have been used in automobile industries. Capek was the first one. He was a Czech playwright, and he was a playwright and an artist who coined this term of robot. That means a laborer, and that's how this terminology came into the picture. So, what was the driving force to have a surgical robot? How did it start? The second point is very important. I'm not going to touch base all the points, but the second point, where the US Army felt that whenever their soldiers are on the battlefield and they are wounded, they need some surgical help, they need medical help. They used to establish these MASH departments, so mobile advanced surgical hospitals. But all these MASH departments were controlled by the surgeons, who are the humans. They used to be on the battlefield, and their life used to get compromised. So the US Army decided, why don't we form a team of robots? They can go to the battlefield, and without compromising human life, we can still attend to the wounded soldiers, and we can treat them. We can give them a primary aid on the field. And that was the concept, how they started developing this surgical robot. So ESOP was the first robot which was introduced to the world in 80s. And there have been different robots. They have evolved over a period of time. They are organ specific. They are general robots. Having said that, when the robots were invented, even for the automobile industry, Isaac Asimov was really worried. He said that robot can have its downside as well. So he jotted down the laws of robot. A robot may not injure a human being or through inaction allow a human being to come to harm. That was called as a zeroth law. That was the law zero. A robot must obey the orders given to it by human beings, except where such orders would conflict with the first law. So here, no harm. That is the most important thing. And a robot must protect its own existence as long as such protection does not conflict with the first or second law. So these were the laws laid down. Unfortunately, in Hollywood and Bollywood movies, all these laws have gone for toss, and you will see all these movies making millions of bucks by exploiting these laws. But in reality, these laws are still being respected. So broadly, what are the types of robots? So in general, we can say they're passive robots or active robots. So you can compare these passive robots where a work has been assigned to a robot, and he or it will keep on doing this work on a regular basis. So it's not a master and slave technique. It's a passive robot. The computer has been fed with the assigned task, and the robotic arms are doing the same job, which is commonly used in automobile industry, and which is active. So the crude example of that is a JCB. It's a kind of a robotic arm, but unless until the master is giving the command, the JCB will not operate. Its arm is still standstill unless it has been given a command. So that is an active robot. Similarly, we have in surgical field, the first generation robots, which were passive robots, Puma 200 used for orthopedic, Neuromet, which was used for doing biopsies, brain biopsies, where there is a navigation, there is a needle, and the needle has been told to navigate through the brain and take a biopsy from a specific spot. So the surgeon is not doing anything. It is the needle and the computerized system which is taking the biopsy. As against the active robot, which is the current system, the Da Vinci system, which is an active robot, totally master and slave technology. Now, what are the different motions we expect? So when we have a normal robot or a normal laparoscopic instrument, not a robot, I'm sorry, then you have 4 degrees of motion. But for a robotic arm, we can get up to 7 degrees of motion. And this is the biggest advantage. I will explain that to you why it is important. There are three stages of, or three different types of surgery which I explained you. One was open surgery, where you cut open the patient, you put your hands inside patient's stomach and operate. Or if you're doing a brain surgery, you open the skull and you operate with your bare hands. In laparoscopy, you introduce long instruments through the patient's abdomen and then you operate. But there have been some limitations with that. Now, this is the chronology of robotic surgery. It started way back in 1985, and now we are in 2020, where new generation robots are getting introduced. Uh, Up until now, like 5 years back, we had only one company which was holding the patent for the robotic surgery, and that was the Intuitive Surgicals. They were manufacturing this Da Vinci system. Currently, approximately 5,000 units have been installed all across the globe, and more than 2 million surgeries have been performed. The safety measure has been checked, and they have been compared with the open surgery and laparoscopic surgery. They are at par in all aspects, including the treatment modality, including its complication rate. Of course, it has got its advantages, which I will explain you in the next slide. But they have been compared at par with open surgery and laparoscopy. Now, open prostatectomy, I'm just giving you an example. This is just a slide. Ignore the title. So this is the kind of surgery we do day in, day out, where we open the patient's abdomen. There are long instruments, your hands are working. The surgeon is trying to peep through inside the patient's abdomen. The assistant is there. He is also trying to put his head. We are clashing our heads. Barely we can see. And this is more so a common problem when we are operating on a gland called as a prostate gland, because it's a very tiny gland. It can turn into a cancerous gland. And the issue with performing the surgery on prostate is because of its location. It's very oddly placed organ inside human pelvis. It is only present in men, and the cancer of the prostate is very common condition. Now, when we are doing laparoscopic surgery, which has been there for the last 40 years, you can see the surgeon is standing, he's holding these long instruments, they are inserted inside patient's abdomen. So there is not a big scar, these are tiny holes, keyholes. There is an assistant who is holding a camera, we are watching it on the television, and the surgeon is maneuvering these long instruments internally. So there is a fulcrum effect. You are trying to maneuver these instruments. You move your hand to the right, the instrument will move to the left. So it's an against action of your own hand. So you have to have a good hand-eye coordination. And at the end of the 3 hours procedure, the surgeon himself is walking like a robot because his shoulders are frozen, his elbows are frozen. It's a very cumbersome surgery, but we have been doing it. Now, you can see this internal view of animated view. The long instruments, they are trying to battle. The surgeon is trying to move them, maneuver them from outside. And it is not as smooth as you would see it in robotic surgery, because at the tip of that instrument, there is no wrist. There is no wrist-like movement. Here, you can see the wrist-like movement, but I'm going to show you this slide later on. So the laparoscopy's downside, you have to have a hand-eye coordination. There is a long, steep learning curve. You have to move the instrument in the opposite direction from the desired target. The current instruments have restricted degrees of motion. So you don't get this 7 degrees of motion. You get 4 degrees of motion. There is also a decreased sense of touch, the haptic feedback. You have to have a good visual cue, what you're looking at. And then with the instrument which is intervening between your hand and the tissue, you have to feel the tissue. So it's not like a natural touch which you will have. Finally, the physiological tremors. If the surgeon has got tremors, those will be transmitted through these instruments, and that could be detrimental while doing the surgery on the particular patient. So why do we need a robot? What was the need of having a robot? So this is a picture, front part of human pelvis, a male pelvis. What you can see is there is a belly button below the. I know that I have to use really basic terminologies here. Below the belly button, you can see there is a balloon-like structure, the pink structure, that is urinary bladder, which is a reservoir for urine. Okay, and below that there is a tiny organ that is the prostate. Now, if you carefully look into this picture, you can see those pelvic bones which are overlapping part of the bladder and the total prostatic gland. So basically, if I have to reach this prostate gland, I'll have to make a cut below his this patient's belly button and go all the way down, depress the urinary bladder, get underneath that pelvic bone, and then access this prostate gland, which is extremely difficult. Having said that, we have been doing this operation for the last 45, 50 years with open way and with a good success. But then the scientists thought that why don't we find a better way and a miniature way of approaching this gland. So this is the anatomy of the prostate, just a short video. You will get to know why what I just said, how this prostate gland is uh, placed in an awkward and odd area. This is the intestine front view. The pelvic bones are on either side. You can see that bladder, that grayish structure, now it has turned pink. Kidneys are connecting to the bladder, urinary bladder. They carry urine from the kidneys into the bladder. And from the lateral side, you can see the urinary bladder at the top, prostate gland, and the urethra in the penis of the patient is starting connected to the prostate. There are a lot many nerves and blood vessels surrounding that area. It's a highly vascular organ. So when we operate, at times, patient can lose up to 1 liter of blood. The rectum is just sitting behind the prostate. They basically share a common wall. And if you see my mouse, the arrow which is moving, we have to remove this gland without damaging the bladder, the rectum, and the urethra. This is part of the sphincter muscle, which is very important. This gives us the control over our urination. So we are continent, we are not leaking out urine because of this sphincter. If this sphincter gets damaged, you can start a continuous leakage of the urine. These yellow things are the nerves and red and blue things are the blood vessels. Yellow things are also important because they control the urinary or the urethral sphincter, as well as they control the erectile ability of the patient. So if these nerves are damaged, patient can permanently lose his erections. So we have to preserve all these structures as far as possible and then remove this tiny gland which may be harboring some cancer and rejoin this bladder part with the urethra. Now this is the today's generation Da Vinci Xi machine. It has got 3 components. The first one is a 4-armed robot. It has got 4 arms. You can see that clearly. One arm will be holding a camera, which is a 3-dimensional camera. And the 3 arms are there for surgeon to use his or her various instruments, which could be a scissors, a grasper, a cautery machine, and it can be interchanged with any other equipment which is required. The middle part is called the vision card. So it gives a high definition image of the patient's inside. And this is basically the CPU of the entire system. The third equipment is the surgeon console. So all 3 equipment are talking to each other while we are operating. The surgeon console, so surgeon is basically sitting on this console. He has got a joystick. He's got 2 joysticks in his hand. You can also see those yellow and blue joysticks which is basically which is to be done inside patient's body. So all the instruments are operated through these joysticks. In the middle, you can see a viewfinder. This viewfinder gives us a 3-dimensional vision, which is beyond our imagination. So I generally feel as if I'm operating through patient's body. So I'm sitting inside patient's body and I'm operating on that particular patient. It is that kind of vision you get. You can see the tiniest vessels very well. It is a 10 times magnified view. There is a microphone which is connected to this viewfinder so that you can communicate with your assistant while doing the surgery easily. Just trying to move over to the next slide. Okay. This is a typical view, a bird's eye view of operating theater. So the patient is lying on the bed in the middle. There is an anesthetist. The robot is connected on the left side of the patient. That is called as docking of the robot. And you can see the surgeon at the bottom of this picture. You can see the surgeon who is sitting over the surgeon's console and operating that robot. So surgeon is nowhere close to the patient. Only the surgical assistant, anesthetist, and a nurse will be there next to the patient. This is a master-slave technique. Unless until surgeon moves his finger, there is no movement of the robotic arm. So this is how it actually looks. This is the surgeon. The assistant is operating the actual robot. She's taking out the equipment and she's replacing it with the another equipment. Patient's console has got these joysticks. These movements are extremely refined. So if surgeon has any tremors, those will be abolished by this robot. This is the viewfinder. That is a 3-dimensional viewfinder. It gives 10 times magnified view. And this is a video of how it looks outside patient's body. So when the surgeon is making any movement, the instrument is working inside. These are all interactive equipment, and you can also teach your colleagues, which is called as a dummy console, which is a second console. You can always take over the function of the assistant's console over you in case he's doing any mistake. So it's an excellent teaching tool as well, because one cannot imagine how you can see inside patient's body in a 3-dimensional view, high definition and magnification. So it's an excellent teaching tool as well. So in years to come, this is going to change the teaching perspective of the entire medical fraternity. So another video, this shows how clean and how refined movements of the robotic instrument. Concentrate on that endorist element of the instrument. It is actually making a movement which is better than and more refined than a human wrist. Human wrist can make an action which is called as circumduction 360 degrees, but a robotic arm can make a movement of that circumduction 570 degrees. So the range of movement is increased by nearly 60 to 70%. What are the advantages of robotic surgery? So as we know, this is a miniature surgery, so incisions are smaller. Because the incisions are small, the pain will be less. The blood loss is much less as compared to open surgery. As I told you, open surgery, we may end up losing 1 liter, up to 1 liter of blood during this prostate surgery. But with robotic surgery, it could be as less as 100 mLs. There is less tissue handling. Because the incisions are small, the chances of infection are less. The scarring would be less, so it is cosmetically very effective. As a result of small incision, the hospital stay is shorter and the recovery period is shorter as well. The article which I mentioned you in, which was published in The Week, the person who was running the marathon, he started running his marathon within 4 weeks, which wouldn't have been possible with an open surgery, that's for sure. And he's still doing it. This is the comparative picture showing the difference in the size of the incision. So in the first picture, you can see how we take the incision for prostate surgery. Of course, these incisions will vary from side to side. If somebody has to have kidney surgery, the incision will be much higher towards the rib cage, and that will be much bigger than what is shown up here. And in the second picture, you can see these are tiny holes on patient's body, and that's it. So all those advantages we can take. Currently, what are the specialties which have been using this Da Vinci robotic system? Urology, which is my specialty, they have exploited it more so because of prostate surgery, liver and colorectal, gynecological surgery, general surgery, ENT and head neck surgery, as well as cardiac surgery. So this paradox, you can imagine, actually the robot was first bought over by cardiothoracic surgeries in Europe. And later on, they found that it was not as useful in cardiac surgery. So urologists took over the robot, and they found that it was the most useful equipment for removing the prostate. And now we are the leaders in exploiting its usage. Now, this is the actual intraoperative surgical thing where a prostate has already been removed. And what we are trying to do here is reconnect the bladder, urinary bladder, with the urethra. So just look at the refinement and the finesse of this equipment, the magnification.
The posterior anastomosis is then performed beginning at the 5
So we are
o'clock
trying to
position
suture
and running
the
posteriorly
tissues.
to the 9 o'clock position.
Sorry, this video may be
We begin with an outside in
objectionable
stitch
for
on the bladder
few
side,
of you, but
followed by
you
an
can
inside
always
out on the urethra.
put the video off for the time being, maybe for the next minute or so. Now look at the wrist movement. This is not possible with human wrist because we are already inside behind the pelvic bone. With human wrist, this is extremely difficult to take this kind of stitch. But look at the robotic endo wrist. This is a boon for us. This just makes our life so easy. And I'm sitting over the console. If I wish, I can have a sip of coffee while
The
having
sutures pass
doing
3
the
times through
surgery,
the bladder
though we don't
and
do it
twice through
normally,
the urethra.
but it's all possible.
Once this is done, we are ready to bring the bladder down to the urethra.
And just to tell you, the first transatlantic surgery was performed a few years ago, where the surgeon was sitting in New York, and the patient was in Strasbourg, France. So it was a transatlantic robotic surgery that is doable.
The reason that the upward direction
That kind of surgery is
down
not going
is
to
because
be
it provides
popular
the
as of
appropriate
now
tension
because
in
of the
direct direction.
legalities involved.
Here you can
And
see the
secondly,
suture being elevated
there is still
and the
a
head of
lag
the specimen
involved in
straight up,
transmitting
and
the
this allows the bladder to slide
impulses
nicely
from
down to
the master machine to the slave machine. But that is doable. That's how the dream, which was seen by the US military, could actually
Key
come
to
in
performing
reality.
the urethrovesical anastomosis
So this is
running
just
the
an
setup.
overview of how the
It's
robotic
helpful to have a long
surgery takes place inside patient's body. Now, we are moving ahead. Now we need to have more and more from this robot. We need to introduce the artificial intelligence system with the robotic surgical robot. The first and foremost, where the scientists are working now, is the haptic system. We're still losing that touch. I'm sitting in the corner of the operating theater. I'm operating on a patient, but I don't get the touch of the tissue, which is very important. So the scientists are already working over it, and it's not too far from getting into the haptic feedback technology. So the haptic will work with force sensing, position sensing. The visual imaging is still important. We are getting three-dimensional magnified view, so visual cues are important. Electrosurgery is getting advanced, pressure system, the pressure of the tissues, and thermal sensing. So what are the expected advancements in the near future? Navigation. Navigation is very important. So preoperatively, before the surgery, if I know that I have to operate on a tumor which is only 2 centimeters size sitting inside a kidney, without disturbing the kidney musculature, if I have to get inside the kidney and remove only the tumor, then this navigation is going to help me. So what I'm going to do is superimpose my MRI and CT scan images. They will be fed into the robotic system. The robot will know where exactly to go. So it will keep on guiding me when I'm operating on that kidney, and I will remove only that tumor without much damaging the surrounding tissue. So that is a navigation system. It is underway. Again, in the next 5 years, that will come up. We should be able to use these robots in any operating theaters. Currently, there is a restriction. We cannot move these robots easily. They are quite bulky. We need a specific uh, amplification of the electric current for these robots. We have to use a very um, high-speed internet, because all these robots all across the world, they are connected, they're talking to each other, and they are monitored real time. If there is any glitch, the real time solution is found and they are fixed then and there. We should have a single platform for different organs. We should not have a separate robot for knee replacement, separate robot for spine surgery, and separate robot for prostate surgery. We should have a single platform. Haptic feedback, as I mentioned you, automation in certain areas, artificial intelligence. I think it is going to come up in each and every. That's going to be our day-to-day life, just like Alexa or Siri, and the organ-specific system. Now, this is too technical, but I thought because I'm giving a talk to the Technological Institute, this is how they are working over this developing haptic feedback. This is by judging the force from the tissue, the torque, and even the feel of the tissue by various methods. I don't understand much about that. So this is the prototype which they have developed for haptic feedback. And this is going to be a biggest advancement in the field of robotic surgery. So as I mentioned, in in open surgery, we get full haptics because we are actually touching the tissue. In laparoscopic surgery, the surgeon's hand is intervened by the long instrument. That's why the feel what we get from the tissue is an indirect haptics, which is not as effective. But currently in robotic, we don't have any haptics whatsoever, because the instrument is far away from the surgeon and there is no direct contact. It's all indirect contact. That's why haptics is very important, and the true haptic display, if it gets developed in the near future, will be very much advantageous to us. So there have been many studies going on. We are not far from there. Maybe in the next 2-3 years, we'll have the first generation haptic, and in 5 to 10 years time, we'll have a really refined haptic feedback. The other thing is the advanced intelligence system for robotics through virtual reality or augmented reality. So there are two types of head-mounted displays, devices. The virtual reality, where actually you are seeing when you're operating, and that is animated view. But in augmented reality, those are like Google Glasses or Microsoft HoloLens, where there is a superimposition of normal tissue and at the same time animated view. So both technologies are getting developed, and they will be introduced shortly in robotics. What is going to be the next step? We are seeing minimal scarring on the body, minimal incisions. So we take about 5 to 6 incisions. But now the next thing is going to be single site, single port surgery, laparoendoscopic single site surgery, that is called LESS. So instead of making 6 openings, you just make 1 opening. Through that 1 opening, you introduce all the 3 arms with miniature instruments. Those arms are crossing each other. If you can see the bottom part of the picture, they are not straight instruments. they are crossing each other and then they are meeting again, giving a kind of a 180 degrees of curvature for both the instruments. And then you can do the same procedure what we have been doing inside patient's body. And this technology has already been developed. The Da Vinci SP system has already been introduced and FDA approved. It is launched and people have been doing this single site surgery. So basically this is about the uncoding the Da Vinci code. We have come a long way. It's 20 years since the first surgery was performed. In Mumbai, we have got almost 12 machines installed all across Mumbai. In Hinduja, ours is the only system which is a fully robotic system. So we have got the Da Vinci Xi, which is the latest robotic system. And our system also has got incorporated robotic operating table. So I'll give you an overview of how it works. So the robot, when it is docked to the patient's body, when it is connected to the patient's body, we cannot move the table. Suppose if I have during the surgery, I feel that I need to turn the patient on a little bit on the right side, 10 degrees right. What I'll have to do normally is undock the robot, disconnect the robot from patient's body, turn the patient's body or the table on right side or left side, and reconnect the robotic arms. And that is time consuming. So what we have got is a robotic table that is called motion table, wherein the table is connected to the robot by a Bluetooth technology. And whenever I want to move the table will send a command to the robot and simultaneously they will move together. So we don't spend too much of time in undocking the robot and move the table. So this is the only place in India where we have got the entire robotic system, comprehensive robotic system. It's been 3 years since we have installed it, and we have done over 200 surgeries across different specialties. So anyways, that's a brief overview about the Da Vinci robot. And thank you for being patient. If you have any questions pertaining to this technology, I'm more than happy to take those questions.
Any
Yes, sir. There are
questions?
few.
Yes.
I will read it out. Yes, there are few in Q&A. Progress in robotic technology is commendable. What is the status of use of robotics surgery in India? Are MS students taught how to use robots?
That's a good question, actually. So as you know, the hierarchy system runs like this. We have got the basic medical degree, which is MBBS. Then you get on to becoming a surgeon, master of surgery. And then there is a super specialization, which is either master of chirurgy, which is MCH, or we have got diplomat national board, and both are equivalent. Now it depends on which branch you are in. So to give you a shorthand answer is yes. If you are doing a Masters of Surgery course, during the course you may not get hands over a robot because you are still learning your basic principles of surgery. This is an advanced technology where you have to already got mastered the basic surgical principles, and then you do this minimal invasive or robotic surgery. So if you are already proficient in the course of Masters of Surgery, then yes, one may get hands on a robotic technology, but per se, you'll have to complete your master's course, and then only you will get on to doing to perform the robotic surgery. Now, in India, I don't have the exact number, but we have crossed, I think, a century of machines in India. We have got more than 100 machines installed all over India, but mainly they are installed in all metropole. So Delhi may have 25 machines, Mumbai we have close to 15 machines, Chennai, Bangalore, and few other smaller places they have bought this technology. It's a very expensive technology. The machine itself cost about $2 million, and the entire the technology, including the table and the affiliated or the allied instruments like ultrasound, it the whole package goes up to more than 20 crores. So the hospital has to be well equipped, and they should be well funded for that technology. But yeah, we are getting there.
Yes, sir. Next one.
Thank you. Nice talk.
How
Thank
safe
you.
robotic surgery in spine surgery?
So your voice was breaking. So was
Okay.
your question?
How safe is the robotics surgery in spine surgery?
So again, that is not my field of expertise, because the robot which is used for doing spine surgery is not a real robot. It is not a master and slave. What I understand is it is a navigation tool. So if you mark the area on patient's body and set the robot, assign a work, then this robot is going to go in that area and probably drill out the bone from a particular part of the spine, and the rest of the surgery will be performed by the spine surgeon. So it is not a classical active robot. I would call it as a passive robot. So currently, it is not a well-established technology. Uh, the active robot, which is the Da Vinci robot, is the established technology all across the board. So in spine surgery, it is still evolving. Same thing goes with the orthopedic surgery, where they use it for joint replacement.
Okay. Thank you, sir. Next one. Can the robotics give some feedback to the surgeon if he is making mistake?
Uh, at this stage, partly yes. So the mistakes are generally not while operating on patient's tissue, but if there is instrument clash, the instruments will freeze. If the instrument is going out of your vision, then the robot will give you a kind of an indication that the instrument is out of your field, which is very important, because these robotic instruments, they're very strong. They can cause inadvertent injuries inside patient's body to other organs. So the key factor is that both 2 or 3 arms which I've been using, all three should be in my vision. If I'm losing one of that instrument from my vision, then it is not good. I may be damaging some tissue inside patient's body, which I will not know until I finish operating, and later on we'll come to know that there was some kind of injury to other organ. Yes, so partly there is some feedback which is given by the machine when the instrument is out of your sight. Currently, we don't get any feedback if we are doing or if we are cutting any tissue which we are not supposed to cut. So that still has to come up. That is going to happen with artificial intelligence.
Thank you.
Sir, age-wise, whether there is any means like suitability for all age patients, robotic surgery, and what is the
Yeah,
failure rate?
so yes, it is suitable for all ages. In pediatric age, we have to, like, infants who are like less than 1 year, or very tiny kids. It may be difficult technology to use, but they have been using it. But otherwise, there is no restriction. You can operate any age patient with the robot. The second question was, what was
Failure
the
rate.
second question? Failure
Failure
rate.
rate.
So failure rate is also minuscule if you are well trained. So failure rate you can classify into different ways. One is the machine failure, which is extremely rare, extremely rare. So in my career, I have seen only once when the robot just failed to operate. It just froze. So basically, I had to call up the company people. They were doing a real-time monitoring of the robot, and they fixed the issue. So it was a glitch. Failure rate of surgery per se, it depends on the surgeon, whether surgeon has chosen the right person, right case to operate on, and whether he has got enough experience. So that will vary from person to person, but most of the people, they have to go through a rigorous training. They have to go through a certification course. They have to get a mentor when they start operating. So somebody is supervising them, some trained surgeon is supervising them. If they are in difficulty, they will be bailed out by that surgeon. And once everyone is happy that, okay, this person is safe enough to operate using a robot, then only he is allowed to operate. So there are stringent protocols which have been used. That's why the failure rate is extremely low.
Okay, sir. Any other question? Maybe one question we can take up. Sir, will you please stop presenting from your Google Meet? Yes. Just a minute.
Thank you very much.
Sir, 2 minutes, please.
Yeah.
Over to you, Milind, sir.
Yes, sir. Dr. Nagaonkar, sir, it was very nice explanation with very fantastic animation. I would like to thank you for showing us how robotics can work in the field of surgery. Also for giving us insight about the robotics and its working. So after looking the presentation and all the things, I would say the doctors are next to the God. Okay, with this quote, I would like to thank you for enlightening us with your words. And please consider a small token of appreciation from the Sardar Patel Institute of Technology and from the FDP team. This is a virtual memento.
Thank you. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir. Yes. Deepali madam, would you like to say something? Meanwhile,